was built to last. With the webs I'm weaving, I could change the past with all my.
Hello everyone, welcome back to another video on the channel. This is going to be the endocrinology episode. We're going to basically use AI, and specifically in this video we're going to be using ChatGPT version 4.0 to create our own border style internal medicine questions and answers and master this board taking. By basically solidifying all these different educational objectives with more and more questions, because the best way to actually learn is to apply your knowledge, and to apply knowledge in many ways, as many ways as possible. So basically what you will see in this video is we're going to go through 3 endocrine questions that are driven from the internal medicine question bank educational objectives that also are on ACP, and basically the educational objectives are input into the AI machine, and the AI, based on the way I've asked it, will create new multiple choice questions, and then it will also analyze the answers and go through the answer choices. So let's go ahead and get started. So it says here is the first question. Very short and concise. We have a 58-year-old male with CKD stage 4. He presents with erectile dysfunction, decreased libido, and fatigue. Over the past 6 months, he denies any gynecomastia, galactorrhea, and the lab tests show a mildly elevated prolactin, which is 85, and a low testosterone level. His symptoms persist despite the adequate hemodialysis. Which of the following is the most appropriate next step in the management of this patient? So go ahead and pause the video right here, pick your answer, then we're going to go through each of the options using AI. All right, so this is a very important question, very pathophysiology-based. So hyperprolactinemia is very common in CKD individuals due to the increased prolactin levels, which basically is from reduced dopamine inhibition and decreased renal clearance. Prolactin levels are typically mildly elevated in the CKD group, so less than 100, which is an important number to know, because greater than that, we should be suspecting other secondary causes of elevated prolactin. Sexual dysfunction in CKD is also multifactorial. It's not just prolactin, but it is possible. You can have sexual dysfunction in CKD that arises from neuropathy, vascular problems, and you name it. Medications can always do that as well. So in this question, the patient does have hyperprolactinemia, and the answers are as follows. Prescribing bromocriptine or cabergoline. So this is the correct answer because it's a dopamine agonist. When you use bromocriptine or cabergoline, you can reduce the prolactin levels and improve some of the symptoms of sexual dysfunction in these CKD individuals. Starting a testosterone therapy would be wrong, because low testosterone, although it's common in CKD, this is not going to improve the symptoms significantly. Initiating hemodialysis, this would be wrong, because prolactin levels in CKD do not respond to hemodialysis, which is why originally they're even elevated. Ordering a brain MRI to evaluate for a prolactinoma, that would be wrong, because remember that prolactinomas that are caused by tumors cause a much greater amount of prolactin level, likely greater than 200. These mild elevations do not trigger for us to get an MRI. Reassure the patient and monitor, that would be wrong, because again, the patient is symptomatic and there is a treatment that you can offer to this patient. So Let's go through the algorithm, right? So the CKD plus a mild hyperprolactinemia less than 100, you do consider a dopamine agonist. If you have a CKD and a very high prolactin greater than 200 is when you really need to start thinking about a prolactinoma, and you could get the MRI of the brain. Now, persistent sexual dysfunction despite prolactin treatment, this could be multifactorial, so you need to start looking for other causes of prolactin elevation in that patient. So in terms of pattern recognition, mild prolactin elevation plus CKD, think about dopamine agonists that you can use to treat. If you have someone with a CKD plus high prolactin, and that prolactin is less than 100, do not think about a prolactinoma and getting an MRI of a brain unless that prolactin is very high or for some reason not responding to treatment. A testosterone replacement is not going to fix the CKD related hypogonadism because the issue is prolactin, okay? Even though this patient does have low testosterone. You can also do more harm than actual treatment there. So let's go to the color-coded answers again, kind of going through prescribing the bromocrine or cabergoline, these dopamine agonists, and why the other answers. All right, and then I think I also asked it to create the latest, just go through the answers based on the latest American guidelines and treatment protocols. So they are currently dopamine agonists, the first line treatment for hyperprolactinemia in CKD patients, and testosterone therapy is not recommended, and then hemodialysis does not normalize prolactin levels. These are all checked based on the latest guidelines that these engines are able to access. There's some controversial facts with other engines that say some of the guidelines that are incorporated into the GPT system may be from 2020 restricted to 2021, but we have to check that. I'm not 100% sure on that. All right, so the high yield takeaway point at the end also, CKD patients may have mild hyperprolactinemia due to impaired clearance and increased release. Treatment with dopamine agonists can help, but sexual dysfunction may persist, and there may be other factors. All right, so let's go ahead and move to the next question. All right, this is a 67-year-old male, okay, who is admitted to the ICU with sepsis due to pneumonia. His medical history includes hypertension, type 2 diabetes. The routine labs will reveal that there's a TSH of 0.2, there's a free T4 of 1, and then a total T3 of 45, which is low. And the patient is hemodynamically stable, but he remains fatigued and lethargic. Which of the following is the most appropriate next step? So go ahead and pause the video right here, pick your answer, and let's go through the options together. All right, so this is a question about Euthyroid 6 syndrome, or ESS, aka low T3 syndrome. It occurs in critically ill patients, as you know, due to decreased conversion of T4 to T3, which pathophysiology is related to 5-monodeiodinase suppression. And then the TSH may be low or normal, but the T3 is consistently low due to illness-related metabolic changes. So thyroid hormone replacement is not recommended in these cases. Thyroid function typically normalizes after recovery. So this is what you need to remember about Euthyroid 6 syndrome is this is a temporary event. So let's see here. Repeat thyroid function in 6 weeks was the correct answer because ESS is a transient illness and thyroid function usually recovers after the underlying illness resolves. Starting levothyroxine would be wrong. Remember that T4 levels are normal in this case, and treating ESS with thyroid hormone does not improve outcomes, actually may lead to more complications. Administering lithyrionine or T3 replacement, that would be also wrong. Replacing the T3 is not beneficial and can even be harmful. Ordering the thyroid stimulating immunoglobulin or TSI would be wrong. This is usually used for Graves' disease, right? And is unlikely in this patient here, since the patient has low T3 and no hypothyroid symptoms. To obtain an ultrasound, that would be also wrong, because euthyroid syndrome is not a structural thyroid problem. So the algorithm is, if you see a critically ill patient with low T3, you want to think about euthyroid syndrome. Low T3, normal T4, and a low TSH, which were in this case were all given to you. Sometimes they may not give you and ask you what you're going to do in this case. Then in that case, you would have to order a total T3 yourself. But this question was kind enough to give you T3. So now, once you see that there is the suppressed TSH with elevated, with a normal free T4, and you got your T3 and then the low T3, then you have officially diagnosed euthyroid syndrome. And in this case, we get here. So you think that this is a ESS and not a primary thyroid dysfunction. The management is supportive. You repeat the thyroid function test after recovery. But you can just imagine how many ways boards can ask this question. So pattern recognition, just remember this, a hospitalized patient with low T3, if they don't give you low T3, you ask for it. Thyroid function will normalize, so no treatment will be needed, and then do not replace it. And then again, the latest American guidelines do not treat euthyroid syndrome. TSH may be low or normal in ESS, but T3 is consistently low. Thyroid function normalizes after illness resolution. So recheck, all right, in 6 weeks. And these are the wrong options as it presents them. And then the high yield facts about ESS, which is a transient thyroid dysfunction seen in critically ill patients. And T3 is low, T4 is normal, and TSH is low normal. Let's have that very, very kind of solidified in your memory. And don't forget about this condition, as especially an internist or anyone working in internal medicine or planning to do a fellowship. All right, so let's go ahead and move to the next question. So this question is a 52-year-old woman. She has a BMI of 34 and a history of type 2 diabetes and hypertension. She was started on Orlistat for weight management. She probably could not afford a GLP-1 or had an issue with it. They were not able to give it, so they tried to give her Orlistat, although I'm not sure how much more affordable Orlistat would be. 1 week later, she returns to the clinic complaining of abdominal cramping, increased flatulence, and oily stools. She denies any fever, nausea, vomiting. She reports that she recently started a high fat ketogenic diet. So what is the most appropriate recommendation to improve her symptoms? So go ahead and pause the video right here, pick your answer, and then let's go through the options together. All right. So pathophysiology. So Orlistat. Okay, so this boards love to ask about Orlistat, its mechanism of action, and everything else. So Orlistat is a pancreatic lipase inhibitor. It reduces fat absorption. Okay, so it can cause increased fecal fat excretion. So all these symptoms that you were seeing make sense there. Patients, especially who consume high-fat diets, which means greater than 30% total calories from fat, can develop fat malabsorption symptoms, such as the GI symptoms. And so the treatment in those cases, if somebody, like in her case, if you reduce the dietary fat intake, you will be able to fix the symptoms. Now, the correct answer is given. Orlistat when works best when paired with a low-fat diet. Patients with a high-fat intake experience GI side effects, which can be mitigated by reducing the dietary fat. Stopping it would be wrong. Stopping the medication is unnecessary at this point. You can just modify because the patient is telling you it's a high-fat diet. Now, if the patient is not taking a high-fat diet, they're on a protein diet, or they try to tell you that, in that case, there's you cannot adjust that, so you may even have to stop it. Prescribing the pancreatic enzyme replacement, so that would be wrong, because this is for exocrine pancreatic insufficiency, such as like in chronic pancreatitis, cystic fibrosis patients, and does not address the issue, which is the Orlistat. Starting a bile acid sequestrant would be wrong. You remember the bile acid sequestrants such as the cholestyramine, they treat the bile acid diarrhea, not the Orlistat related staturia. And ordering a stool test for fecal leukocytes, that would be wrong. This would be, for example, if you were looking for infection or inflammatory diarrheas, and that wouldn't make sense here. So the algorithm, you have a patient on Orlistat with GI symptoms, think about their diet. If they're taking a high fat diet, reduce it to less than 30%. If they have, you reduce them and they have persistent symptom, think about alternative causes, or you may have to stop the medication and switch it to something else. And again, the pattern recognition is here. And the latest guidelines. So Orlistat is FDA approved for obesity management in patients with BMI greater than 30 or BMI greater than 27 with comorbidities. Okay. Patients must follow a low-fat diet, less than 30% total calories from fat to avoid side effects. Orlistat reduces fat-soluble vitamin absorption as well. So patient should take a daily multivitamin. And also, this means there's another window of opportunity for boards to question you, somebody on Orlistat developing a complication of the multivitamin deficiencies, the ADEK vitamins, right? So this kind of takes on the high yield point takeaway. Orlistat inhibits the fat absorption and requires a low fat diet, high dietary fat intake, and 30% leads to oily stools, flatulence, GI discomfort, and also the vitamin malabsorption. And that is it for today, guys. I hope you enjoyed the video. This is a new format of the video. This way we are able to really get to the matter of fact and really get to the gist of that question that is going to be tested on boards. So if you enjoyed the video, please like and subscribe, leave a comment, let me know if you want any more modifications or any changes or any topics that you want me to cover first. We're going to try to produce a video every day and really go through all of the educational objectives that are really high yield on internal medicine from all categories. So I'll see you on the next one.